Thank you, José Antonio, for this insightful presentation. Well done. It's a pleasure to be here along with you again. And I will take the opportunity to encourage our audience to send questions. And we actually received some questions. First, I would like to take a picture from your presentation. As I can tell you that it was really beautiful to see that fluxogram from the Mexican guidelines. Well done. It's a clear message to up-titrate, and you also have put together several information regarding some 2 or 4 weeks to get it done. So I believe time is really important for heart failure assessment, not only for myocardial infarction, but even more important for heart failure. And we actually we don't see this kind of recommendation in international guidelines. I would like to have your thoughts on that.
Yes, in our document, we consider that it is not enough to think in terms of qualitative treatment. We must think in terms of the most benefit in the early period. So the message, the essential message, is that we don't wait until the patient was decompensated or is referred to third level university hospitals to improve the prognosis. Even in the first level of attention, even in the hands of primary care physicians, of internal medicine specialists, we must to remember that the time is muscle in the myocardial infarction, but in heart failure too. And for this reason, we recommend that the foundational therapy must be implemented in no more than 4 weeks. But as we can see in the case, many patients with the 4 pillars remain at high risk of adverse events. So for this reason, we must to make a step forward. And the optimization with a comprehensive evaluation and approach must be very fast. And for example, in terms of the heart rate control, we don't wait for the compensation episode. We must to think about the patient and the needs of the patients. And in a clinical ambulatory scenario, no more than 4 weeks in terms to start ivabradine if the patient do not exhibit adequate heart rate control with the monotherapy with beta blockers. It is very important. And in all of our patients during the vulnerable phase, the early administration of beta blockers and ivabradine leads very, very important benefits in terms to up-titrate the dose of beta blockers in these very frail patients. And for us, is by now a new paradigm and a very good clinical tip in terms to optimize the patient's treatment.
I will take some questions from the audience, but first, I would like to dig deeper into that vulnerable phase that you highlighted and well described for us. And I believe it's such a challenging scenario, right? The vulnerable phase, and it's the patient usually present an ongoing congestion, and it's really difficult for us to up-titrate beta blockers. And you suggested to introduce ivabradine as early as possible to reduce the risk by reducing the heart rate and introducing ivabradine. So this is a really great tip for the audience that are listening to us, because the real world is quite difficult and really challenging scenario for us to up-titrate all the medications. So ivabradine, I believe, steps in really in a favorable fashion in order to give some room to optimize the patient. So I would like to highlight this and want to hear your comments as well.
Yes, of course, this is a very challenging patients and very frail patients, and congestion still remains in over 20% of patients at discharge. For this reason, we must be ensured that the patient is fit for a safe discharge. But even if the patient in an apparently euvolemic state, the up titration of the dose of beta blocker is not well tolerated in this kind of patients. And for this reason, this combination of drugs is a very good option, and it's very safe. And as you can see, led us to the rapid up titration in the next months for the another drugs like sacubitril valsartan or even beta blockers.
Fantastic. So allow me to take one question from the audience. Dr. Rafael Nardinelli, which is a great friend and also a fantastic heart failure physician from Brazil. His question is regarding digoxin. So it's difficult for some countries to afford for heart failure therapies, and digoxin might play an important role in those countries. But what are your thoughts on digoxin use? How have you been using? I saw in your Mexican guidelines fluxogram that digoxin is, a third line or even a fourth line therapy. So what are your thoughts? Are digoxin only meant for patients with atrial fibrillation?
Yes, by now we still use digoxin. Digoxin is very well accepted in a classical think of in the oldest cardiologists, and indeed the National Institute of Cardiology in Mexico. The logo is the digoxin plant, but we must to remember that digoxin is excellent in terms to improve symptoms, but the evidence cannot show that the use of digoxin improves the prognosis of patients. So for this reason, digoxin must be restricted in a patient who receive all the foundational therapy, the comprehensive evaluation, the additional second-line therapies, which evidence of disease modify, like such as ivabradine, and for the control of heart rate in the AF patients only, because it's a good drug, but is not be considered by now as a first line or second line, because it doesn't improve the prognosis of patient, and in some cases it could be a little bit risky, especially in patients with renal dysfunction, for example, electrolyte disturbance, for example.
Yeah, I fully agree on that, and I also like to highlight that digoxin has a toxicity profile. So we should take into consideration that some patients might, might worsen due to the digoxin. But I believe it still play an important role in patients with AF. But there are so many heart failure therapies that have shown improved outcomes rather than digoxin, and also safety is a concern regarding digoxin. But thank you, Rafael, for this great question. And Dr. Ibrahim Idris, I believe I pronounced it correctly, asked about if amiodarone might play a role in reducing the heart rate in patients with HFrEF. What's your take on that, Dr. Jose Antonio?
I'm sorry.
Amiodarone. Does amiodarone, yes, plays an important role in reducing heart rate?
Yes, of course. Amiodarone is another option for the rhythm and rate control in AF patients with heart failure. But we must be very cautious in terms of the potential adverse outcomes related to the use of amiodarone, especially with regard to thyroid function and some pulmonary adverse events related. We use amiodarone in our program, but this is not a routine use, no? for this patient. And obviously, if the patient has AF and myocardial damage, it is in the guidelines considered as a first option for the control. But by now, almost in the third level hospitals and university hospitals, we must to consider the invasive treatment in some cases in terms to the ablation of pulmonary veins, for example, in terms to reach the adequate control for heart rate, atrial fibrillation. And Pedro, I have a question.
But let me just make a brief comment on that, and then shortly after I'll leave to you. But I believe that we need to clarify that amiodarone is an antiarrhythmic drug. It's not a heart failure drug. So you might use along with the heart failure treatment, but not for heart failure. You might use for rhythm control. You might use for heart rate reduction in patients with AF or atrial flutter as well, but it's not a heart failure drug, and you should not use amiodarone to further reduce the heart rate. You should use beta blockers and ivabradine in that direction to reduce the heart rate, not in sinus rhythm. So it's important to clarify this statement for Dr. Ibrahim.
Absolutely agree. And I have a question for you, and maybe it's a challenging question. By now, the evidence exhibit clear benefit of the heart rate reduction in heart failure patients. But unfortunately, in the real world, less than 50% of patients reach an optimal heart rate. Do you believe that heart rate is the forgotten clinical variable in heart failure?
I not only agree with you, but I can tell you that it's even worse in our Brazilian scenario. I believe that a lot of physicians still not believe that heart rate is not only a marker of worse prognosis, but mainly a risk factor that demands further action and further treatment. So heart rate has been broadcasted a lot in our guidelines, in congresses and so on, but I believe there's still a huge gap between this information from the guidelines, from the clinical trials, and the real practice. There's a huge gap between them, and we should use this kind of webinars and also congratulate this initiative in order to improve the awareness of the heart rate, not only as a prognosis marker, but a disease-modifying target. I can define this heart rate role as a disease-modifying marker
of experience that systematically demonstrated good results, not only in terms to control the symptoms, indeed in terms of improve the prognosis. And by now, we must to use that and early as if possible. It is very, very important. And in some patients, we have a lot of problems in terms to optimize the doses of the 4 foundational pillars. One of these problems is the blood pressures. And what, in your experience, is the role of ivabradine in some cases of patients in an ambulatory setting, like your case, with low blood pressure and the use of ivabradine?
Thanks to bring this issue up again, and it's important to highlight that it's a worldwide phenomenon, this clinical inertia, and we should come up with different approaches in order to overcome those barriers and improve heart failure care across the globe. But it's important to highlight that there might be some reasons why the physicians are not prone to optimize. I believe we should first highlight the severity of the disease, and this disease is our heart cancer, right? So it mirrors the cancer prognosis. So as heart failure is our cancer, we should come up with more aggressive approaches in order to optimize the treatment. So a possible side effect is a minor reason comparative to the benefits of the heart failure treatment. So this is also considered to be a green light for us to be even more aggressive to up-titrate those medications. And of course, low blood pressure is always a challenge when we are managing this kind of patients. And I highlighted this with my clinical case, as ivabradine played an important role as a catalyzer, a catalyzer for the heart failure treatment. So ivabradine stepped in and allowed brought some room, brought some space for the hemodynamic. So sacubitril valsartan was up-titrated successfully, and 6 months later, the patient was completely asymptomatic and a recovered ejection fraction. So I totally agree with you on that. And I believe we are reaching the end of our webinar, but I think there's also another one possible question from the audience. I would like to hear your thoughts on that. Are there any targets in patients with atrial fibrillation? And how about ivabradine increasing the risk of heart failure? What's your opinion on that, Dr. Jose Antonio?
Well, in atrial fibrillation patients, the goal is the same, less than 70 beats per minute as a mean heart rate. And there, in the past, we have some concerns about the association between the use of ivabradine and the development of atrial fibrillation. But by now, this concern was disappeared. The black box is not exists anymore. And obviously, if the patient has electrophysiological substrate for atrial fibrillation and the heart rate is lower than 50%, for example, with the combination of high doses of beta blockers plus ivabradine, we must be very cautious because all the Rentran circuits who lets the develop of atrial fibrillation could activate it and develop episodes of atrial fibrillation. For this reason, we must keep that the patients with the drugs must be over 50%, 50 beats per minute of resting heart rate, for example. And this is a concept that we use in our program. We educate our patients and the caregivers in terms to must be checking the heart rate, the use of devices like electronic devices like Apple Watch, for example. And by now, we didn't show high risk of the use of ivabradine and the development of atrial fibrillation episodes. It's very, very good and safe drug.
Yes. I also would like to point this out because ivabradine has such an outstanding safety profile that you should not be concerned on prescribing it. So Daniel, thank you so much for your question, but you should not be concerned on that. You should prescribe this without any major concerns. And I believe we have just 1 minute, so I would like to give the mic to you, Jose Antonio, to end our webinar, but I would like to take the opportunity to thank again all the audience and Servier and also TMA for this amazing opportunity. And also, it's always a pleasure to be along with you, my dear friend. And thank you so much. And our paper was published today, so it's nice to celebrate this with you and with the audience. So thank you so much for this opportunity.
Yes, thank you, Pedro. Thank you, Servier, for the invitation. And obviously, thank you all the audience for your patience and to be with us in this webinar. I enjoy it very much. And my take-home message is that we must apply in all patients a comprehensive evaluations and moving beyond the obvious. Heart failure patient is a very challenging patient, and we must guarantee in all our patients that receive the optimal treatment in the shortest time. Only with this approach, we can ensure that the natural history of this disease could be stopped.
Thank you so much. Bye-bye.
Thank you so much. Have a nice day.